Hello, thank you for joining our webinar update today, presented in two segments. This is the second segment. As part of our work to standardize the measurement of the social determinants of health in Iowa, the Iowa State Innovation Model team has invited Dr. David Kendrick to share his experience and knowledge with us. Dr. Kendrick is the founder and CEO of My Health Access Network, Oklahoma's nonprofit health information network, which ensures that every Oklahoman's complete health record is securely available where and when they need it for care and health decision making. A board-certified internist and clinical informaticist, Dr. Kendrick chairs the Department of Medical Informatics at the University of Oklahoma School of Community Medicine and serves as assistant provost for strategic planning at the OU Health Sciences Center. Welcome, Dr. Kendrick.
Hi, thank you very much. I'm glad to be here. So today I'm going to talk to you about our thinking and implementation of social needs screening here in Oklahoma through a project called the Route 66 Accountable Health Communities Consortium. The reason we got into this back in 2008 was pretty obvious from this slide, that Oklahoma tends to rank last or nearly last across lots of health outcomes. And frankly, if you look at the categories here, access, prevention, treatment, avoidable hospital use and cost, equity, and propensity to lead healthy lives, these categories to me indicate how well the health delivery system is functioning, not just health care, but public health, and et cetera. And you can see we don't do well there. So that was sort of our burning platform, our motivation to get to work on this effort. And in Oklahoma, as you may know, we have a health information exchange called My Health Access Network. That was the first project that we undertook together as a community. And you see here the patient home addresses for people who've received care or services in Oklahoma and have their data in the My Health system. So what you see there is really good penetration across Oklahoma and quite a shocking amount of care delivered to people who live around the country. So we've had some success up to date already in working together on improving health and reducing costs. What we see here is a picture of the very first year of the Comprehensive Primary Care Initiative, which was a Medicare-funded project, Medicare Innovation Project. And you see that Oklahoma saved between 5 and 7% a year over the 4 years of that project, well over $120 million that Medicare saved alone in that small pilot program. So, and My Health provided the data and technology infrastructure as well as convening of the community for that conversation. But the social determinants of health, of course, are something that has been discussed for a while. This is a slide from 1999 or a chart from 1999 that really highlights the fact that the healthcare delivery system, even if perfect, is not going to have as much impact on health and well-being as we might have hoped. And so getting into the social and economic factors and behavioral health behaviors is really where the game is, and some to getting into the physical environment. I think we're all in agreement on this. And so recognizing this, CMMI, the Center for Medicare and Medicaid Innovation, which is charged with testing new payment models and innovative delivery system models in healthcare, proposed a model back in 2016 called Accountable Health Communities. What's important about this is it's twofold. One, that the science is catching up with the actual practice of and delivery of healthcare, and two, the largest payer in the world now, U.S. Medicare and Medicaid, are now believers in this, or at least willing to test it, which is a harbinger for what may be coming in the future, which we anticipate to be an increased emphasis on gathering this data and using this data in the delivery of care. But this model is proposed to be a 5-year model. The target population is community dwelling Medicare and Medicaid beneficiaries, notably uninsured or left out of this picture, which is a concern to us and one that we're working with philanthropies to try to cover. Intervention is to systematically screen for health-related social needs, and then to address those health-related social needs through some activities I'll talk more about in a moment. And the outcomes that are being monitored are health quality, utilization, and cost. And this is a chart I won't read all of, but I think it's worth having. This is from Medicare Site, and it basically shows today's care and future care when we use when we do the screening for social needs in the community. And you can see a pretty dramatic difference between today and future, between the individual organizations and doctors trying to get this services versus a community level navigation component to the delivery system, having fragmented community services that are scattered around the community versus having everyone aligned and using common systems, which I'll tell you more about in a moment. So this is basically the model. The model is to take the delivery sites, whether they're the outpatient clinics or the hospitals or the federally qualified health centers or behavioral health facilities, and connect them in a meaningful way with the social service agencies in the community. And here you see 4 of the 5 focus areas, including housing, transportation, food, and public utilities. And the 5th is domestic violence and family violence. But what you'll note about this effort is that there's a circle in the middle called the bridge organization, and that's a role that MyHealth plays to effectively bridge these 2 organizations to one another so that the data can be shared between them that's necessary to deliver the services, so that the identity of patients can be resolved, so that we know that Bob Smith in the clinic is the same Bob Smith that shows up at the utility services, to make sure that the right services are delivered to the right people, and also so that the data can be tracked and outcomes can be monitored and reported on. So this focus is on, as I said, these 5 core areas. There's the option of working in supplemental areas around these other issues, as well as any others we might come up with. So it's a pretty open-ended model from that perspective. But I got to say, just getting these 5 areas, initial core areas are covered, is going to be a challenge. So the reasons that we're eligible for this project, in case it comes open again, is that the providers who in the region have to touch 51% of Medicare and Medicaid beneficiaries. We have to be able to commit to screening 75,000 people a year, with about 3,000 of them that screen into higher risk and therefore get a hands-on navigation service. And the community partners report capacity and geographic reach that is sufficient. And there has to be adequate data connectivity, and this is where MyHealth comes in, and data flow to support the implementation, to support patient targeting, and continuous quality improvement. So one of the things that was helpful here in Oklahoma is that the Oklahoma City County Health Department had already done a project where they embedded navigators in the emergency rooms and did social needs screenings. And they were able to demonstrate early on, in just the initial period of a few months, tremendous cost savings, 127 clients. You can see the cost there for one health system from $416,000 down to $107,000. Another one down by $60,000. So total savings was nearly $400,000 in a pretty short period of time, just a few months. So they became believers, and they ran a second pilot, and they were able to show that not only were cost savings in existence, but 2/3 of the participants were enrolled in primary care. Therefore, they had ongoing access to care and services. And those that had a quarterly visit, 70% of them didn't come into the emergency room at all in the last quarter, even though they were high utilizers previously. So a percent reduction in direct cost was about 60%, almost 60%. So we had that to build on, and as our exemplar here in Oklahoma. Now, the Accountable Health Community Program, you can see here for other regions that are participating across the country, 32 communities total, and both urban and rural projects are in the mix. So there are important partners in this effort you might think about with regards to your community to see if you have someone playing these roles. There's the bridging organization to connect and move the data, that's MyHealth. The essential Medicaid partner, obviously our Medicaid agency. Resource directory. So we have found, and this might be helpful to you, that providers, clinics, emergency rooms are reluctant to screen for things that they don't have any antidote for, they have no treatment for. So in healthcare, we often say, why would you do this newfangled screening test or imaging? Because there is no treatment for the disease. There is nothing to offer the patient once we diagnose it. And in social needs, there is, unfortunately, this is also the case many times. So our experience and this project's approach is not just to do the screening alone, but also to bring in very quickly after we get enough data to identify the need, start to fill in that need on the back end, because we found that that's what drives the responsiveness, especially on the healthcare delivery system side. The navigation services are very important. That's what I'll call the verb in this. They are the ones who receive the positive screenings and turn them into action by connecting the patients with the social needs services in our communities. And the clinical sites, obviously, we talked about a moment ago. And then finally, the social service agencies, those initial 5 are highlighted here. So our budget to do this work is $4.5 million over 5 years, and that's just the way Medicare set out the budget. So what you see here is that the bulk of our funding, about 60% of it, is to go to pay for those navigators and their navigation service. None of the money, unfortunately, is able to go to the social needs agencies themselves. They will need to continue to be funded under their current funding mechanisms, but the navigators will be routing clients to them as they come up. Now, what we're hoping comes from this is a quantifiable number of patients and clients who need services, so that the social needs agencies can start to use our data to report to their philanthropic funders or the state agencies or federal agencies that fund them about their impact on the community, as I was showing you in the previous study. So then you see the bridging organization is about a quarter, and then our technology is about 11% of the cost. So these are the initial target agencies in our communities. You see actually 2 communities there. On the right is Tulsa, on the left is Oklahoma City, and you see dots everywhere. We have the different social needs across those 5. We were actually surprised at how many there were. These are not massive communities, probably roughly 1 million each in their metros, and close to over 200 basically social services that are in our target zone in those 2 communities. So one of the things that we observe about data, and of course MyHealth is a data organization fundamentally, so we talk about it. The claims data is a mile wide, only an inch deep. You can't find anything at all, for the most part, about social needs in claims data. Clinical information is potentially a mile deep, but it's only an inch wide, because real people get care across lots of clinics and across lots of organizations. And the same is probably true about social needs. So here in healthcare, we know that in Oklahoma, nearly half of all patients have records, like medical records, in 2 or more health systems. And this is confirmed by Medicare, that has recognized that the average primary care doctor has to coordinate care with 225 other providers in 117 other organizations. If you add 1 chronic disease to the mix, these numbers climb quickly. Like 2/3 of patients with diabetes have records in 2 or more places. So we come back to the social needs chart again and think about our community of social services. We recognize that our social service agencies are funded by governmental and philanthropic sources. And then there are lots of different social service agencies, and the clients, just like with electronic medical record systems and with healthcare, clients tend to get services. If they get services in one social service agency, they're going to be touched by several social service agencies. And so having the ability to gather the data across these agencies and put it together into one picture for each client is critically important, and is really the brass ring we're going for here, the thing we're trying to achieve, so that we can create a learning system that gets better over time, that helps us to focus our resources in places that need it most. So the basic process for our Accountable Health Communities program is started on the upper right corner there with screening. And then when we have a positive screening, we navigate that person to social service agencies where we connect them, and then we ensure that we have a closed loop so we can actually know who arrived at those services. And so the way this is structured is we have, again, our clinical sites, our payers, our community services, and our navigators. Our clinical sites are these. Of course, we have 211 in the mix. Our community services are these 5. And then we have our initial payers, which are Medicaid and Medicare. We'd like to have other payers on board soon. And then our navigation services are embedded in our county health departments, and MyHealth, of course, serves as a bridging organization. Now, one of the challenges in getting these screenings done was to get them into the workflow. We have not been impressed necessarily that patients would take the time to complete an online survey on their own without some incentive or influence, maybe encouragement by the clinics. So that's the direction we're going with that, is to make sure that they're encouraged in the clinical sites of care. But then we also knew that the screenings had to happen and be done by providers in many cases, especially things like domestic violence, really need to be handled in a little more sensitive way. And so we came up with the idea of calling these vital signs, social needs vital signs. And the social needs vital signs come up, basically are called that for a couple reasons. One is because a vital sign is vital, and we want to make sure people understood the importance of getting these questions answered, just like they emphasize blood pressures, they emphasize taking weights and heights, they need to emphasize asking these questions. And so we basically are recommending and putting together the desk manuals and guides for each of our participating clinical sites to add new vital signs to their electronic health record systems, which is the second important reason for choosing vital signs. In clinical settings, the vital sign section of the electronic health record is almost always configurable and in the control of the practice or the clinic. And so they can add new vital signs as they need to. And so we're recommending they add these new vital signs. And then as they gather that data, the third major component of the reason for calling them social determinants vital signs is that data can be captured almost everywhere the patient presents for care, and that data automatically flows to MyHealth. So we get the data from these patient encounters in something called a continuity of care document, and the information is sent to us. That effectively enables us to have a closed process for screening from the clinical sites to get the data captured and sent into our system centrally at MyHealth, where we can then route the appropriate patients to the navigation service. So the workflow is basically this. They gather the social determinants vital signs in the clinics. We have the claims data and therefore the patient rosters from Medicare and Medicaid. We have any positive social determinants vital signs are routed to the navigators, where they can contact the family and the patients and get them the services they need to connect them. And when they find services they need, they actually make an electronic referral. We have an electronic referral management system, and they can make an electronic referral that comes back into MyHealth and delivers those referrals out to the different social service agencies to let them know to expect this patient or this family to arrive in a certain period of time, and also to make sure that those agencies have the required information they need, like the financial status of the patients and their housing situations and other information that's helpful in these agencies determining who they can serve and who they can't. And so when the service is delivered, then the loop will be closed in the referral system, and everyone who's a party to that patient's care and services or that family's care and services will be made aware of the closed loop. And then, of course, the payers want to know how many people were served and how effectively they were served. And hopefully over time, we'll add additional payers to this mix. So this is a process flow we've developed for this work. It's about to go into piloting, but obviously it's going to change quite a bit over time. And it looks quite complex on the screen here. It is, as you see by the swim lanes, quite a number of different actors working together. But you know, once in place, we're confident that this is going to become a standard part of the way our community does its work together. In fact, we already have a number of other projects that want to do this similar sets of workflow for things in addition to community screening for social needs. They want to do early childhood interventions and other kinds of things. So one of the quick things I would just mention here is that we think of navigation service as transitioning a patient from one place to another, or a client from one place to another, similar to what people usually think of as care transitions, which is patients getting discharged from the hospital, going to a nursing home or a SNF or some other place. In this situation, we're transitioning patients from one place to another, and these referrals constitute, in our mind, physician's orders, and they should be managed as such. So we don't do this over fax, we don't do this over secure email. We do this in an electronic order system so that we can actually keep track of the open and closed loops and understand how many have been open and closed. And so we did a community study in our community early on to develop that system, and we showed in a cluster randomized controlled trial that these electronic referrals were quite effective. And the way we used it is, first we put in care transition management, and we studied the process, and this is what we found was happening in the community. Either patients who were getting seen by their PCP were being told to get their own specialty care or get their own services just by giving them a phone number or an address to go to, or the clinic referral coordinator was trying to manually do that, and it was a mismatch of phone calls and faxes. And on the whole, our initial analysis showed that it was highly ineffective, and the ball was getting dropped constantly. So we began to look at care transitions as orders and standardize the process just like we do with pharmacy orders or lab orders, came up with a series of statuses to track the steps of the process. And what we found was, in the paper world, this is 25 unique states that we determined for electronic referrals and transitions. And the lines connecting these different circles are the workflow in the paper world, which, as you can see, is chaotic and not well designed. So when we went into our clinics then and deployed our electronic referral system, what we found was, in the initial case, a clinic would look like this. This is all referrals made over a period of a year, looking back in time. And you can see that even looking back 12 months there on the far left, July of 2010, 60% of the referrals, nobody knew what happened to them. They were just made and went off into space. And this is, if it's important for referral to cardiology, it's also important for referral to a food pantry or for domestic violence services, and knowing that these things were delivered. So we put in place an electronic process, as I described already, and you see it here connecting the two ends. And if you substitute their specialist clerk for food pantry or substitute, I don't know, transportation, which we have in the system as well, any of the social needs, you can see that this makes an electronic process out of what was paper. And we learned some important lessons, that, it's not enough just to have a standard piece of paper that everybody fills out to make these referrals, or even an electronic piece of paper that's standard. Each receiving organization, like a food pantry, like a transportation agency, they need to know different things about the client. They need to know where they're starting. If they're transportation, they need to know where they're originating, where they're going to, where they need to go back to, what's the timing of it, any special transportation needs. A food pantry needs to know other things. They need to know numbers of people in a family, any dietary restrictions, allergies. And ideally, in our world, as a clinician, I'd like to be able to tell the food pantry this patient needs an 1,800 calorie diabetic diet in order to be healthy. So, and then the last thing, of course, that was critical in this was the workflow integration, and making sure that every party to the referral system was in the same system and able to refer these cases from one to another. And so we did an actual study of two parts of the system, where a total cost of care analysis, and we showed we had a second component that I haven't discussed in our referral system that allowed e-consultations. It allowed the two parties to have a consultation about what to do with this patient or family before the referral happened. And what we showed was, in the healthcare world, $130 per patient per month savings were generated by having those electronic consultations, so that the navigator could basically triage and work out a plan across several agencies at once. So the challenges to address in this space, HIPAA and FERPA and social service agencies all have different data use needs and data visibility permissions. We've worked out HIPAA and social service agencies fairly well. We're still working on FERPA, which you may know is the Department of Education security policy. On the technology end, each organization has to configure their own EHR for gathering these social determinants vital signs. And we will provide a web-based tool they could all use, but it's going to be difficult to get that into their clinical workflows. The data also has to come in the feeds to MyHealth. And the screening implementation, as I've sort of beat like a dead horse throughout, has got to be implemented into the existing workflows. Now, this is a slide actually from a health system in Ohio that they put out there, and I highlight it because I think this is a great way to ask these questions. It's very actionable, it's clear, and if patients are asked questions in this way, they know what the answer is, and they can indicate any one of these they need, And everybody who sees this question being answered knows what to do in response to it. They know what is needed. The questions under the Accountable Health Communities are a little more, I don't know, broad and confusing. What you see here are, and so these are the questions we're required to do as a part of this Medicare project. I'm tempted to pilot both and see how they go, but what you see here is a set of questions that are a little more detailed. Like question 3 there, do you live in any of the following locations? I can indicate the kinds of space I live in. But I'm not sure what to do with that, the answer to that question. What's your living situation today? I have a place to live, but I'm worried about it. I do not have a steady place to live. These are questions that were published in the medical literature, and therefore the reasoning behind asking them exactly as they are printed here. Gathering information on all of the bad things about the place someone lives. Food questions. Have you had food issues in the last 12 months? Have you had food issues, you know, that are somewhat less impactful? That's question 6 and 7. But honestly, I don't know what to do with the answers to those questions. So we really have to have an algorithm for that. Transportation, utilities, safety questions, and there are several of those. So let me go back then so you can see these questions. Those questions are the reason I like these questions, because again, they're clear and I can tell what to do in response to them. And I believe if you have providers advising you on this, that they're going to prefer this format as well. So with that, I will bring it to conclusion. And here's my email address and our website, and I'm happy to take any questions you guys may have. Thanks very much for the time.
All right. Thank you, Dr. Kendrick, for your time and expertise today. The last part having to do with the power of a question and really can we intervene based on certain ways that we ask a question is really important to Iowa. So I believe this information will be helpful as Iowa moves forward with our work to measure and address social needs in our communities. So if there are any questions or comments for Dr. Kendrick, please send me your comments, and I will, in 1 second here, show you. Oh, nope. I will share my contact information with you within the presentation. So let's see if I can. 1 second. And here we go. All right. If you can see that, please send your correspondence to me. I apologize for the glitch there. So thank you again, Dr. Kendrick, for the information, and I'm positive I will be reaching out very soon. So let's see if I can now stop sharing my screen and go ahead and stop recording as well.